In 1905, Ernest Starling defined endocrinology not by specific glands, but by the concept of the hormone, a term derived from the Greek to set in motion. This definition centers on internal signaling loops rather than classic anatomical structures. Many organs, not traditionally classified as glands, function within this system. The heart, for instance, secretes atrial natriuretic peptide to signal the kidneys to begin sodium excretion. The kidneys produce erythropoietin, a hormone that travels to the bone marrow to regulate the production of red blood cells. Even adipose tissue acts as a signal source, releasing leptin to communicate energy status to the central nervous system. Because these signals originate from such diverse tissues, a strictly anatomical approach to diagnosis is often ineffective. Instead, clinicians categorize endocrine failure by its mechanical state: excess, deficiency, or resistance. We will deconstruct the molecular mechanisms behind these three states and map them to the paired axis logic used to identify them in a clinical setting. Understanding these pathologies requires viewing the body not as a collection of organs, but as a series of closed-loop engineering control systems. Hormone deficiency occurs when glandular tissue is physically destroyed. In clinical practice, the most frequent cause of this loss is autoimmune destruction. This mechanism underpins a triad of common conditions: Hashimoto's thyroiditis, type 1 diabetes, and Addison's disease. In hormone resistance, physical hormone levels are elevated, but the biological signal is blocked at the receptor level. Because the target tissue fails to respond, the negative feedback loop remains open. The source gland receives no stop signal and overproduces to overcome the blockade. Genetic resistance is typically severe because it involves permanent structural defects in receptors or signal transduction pathways. In complete androgen insensitivity syndrome, a mutation in the androgen receptor prevents the body from responding to male sex hormones. Despite an XY genotype and high testosterone levels, the individual develops a female physical phenotype. This differs from functional resistance, which is an acquired state driven by receptor downregulation and is often reversible. Type 2 diabetes and leptin resistance in obesity are prime examples of this functional state, where cells desensitize themselves to chronic hormone exposure. While deficiency is managed through physiological hormone replacement, resistance requires addressing the underlying cellular mechanism of the blockade. Hormone excess occurs when a gland begins producing hormones autonomously, ignoring the normal physiological signals to stop. One driver is autoimmune stimulation. In Graves' disease, antibodies bind to and activate the TSH receptor, mimicking a continuous command for the thyroid to produce hormone. This illustrates a G protein-coupled receptor with an activating mutation. A structural defect inside the transmembrane domain locks it into a permanently active posture. This forces the intracellular GS-alpha protein to signal continuously, even with an entirely empty exterior receptor site. If this GS-alpha mutation is localized within pituitary somatotropes, it results in a GH-secreting tumor and the development of acromegaly. However, the clinical outcome changes significantly if this mutation occurs during early embryonic development.
In these cases, the result is McCune-Albright syndrome, characterized by constitutive signaling across multiple tissues, leading to precocious puberty, café au lait spots, and bone lesions. Severe autonomous excess is driven by molecular uncoupling, where intracellular signaling continues without any external regulation. In hereditary endocrine tumors, the specific genetic mechanism of the mutation determines the resulting clinical syndrome. This compares two genetic models: the menin gene on chromosome 11q13 and the RET proto-oncogene. MEN1 follows the two-hit model. Because menin is a tumor suppressor, both gene copies must be inactivated to trigger tumor growth. This loss of function typically results in tumors of the parathyroid, the pancreatic islets, and the pituitary, often called the 3 Ps. MEN2 operates through a gain-of-function mutation in the RET gene. Unlike the MEN1 model, a single mutant allele is sufficient to drive the formation of a tumor. This activating mutation is highly efficient at initiating medullary thyroid carcinoma and pheochromocytoma. The clinical triad for MEN2A includes these tumors alongside hyperparathyroidism, while MEN2B is marked by mucosal neuromas. The aggressive nature of the RET mutation means that identifying a single genetic hit is sufficient evidence to recommend prophylactic thyroidectomy.
Moving from molecular models to the clinic requires a method to distinguish normal hormone variations from pathological autonomy. Diagnostics rely on two antibody immunoassays, which use chemiluminescent or radioactive detection to measure hormone levels at extremely low concentrations. A central rule in these tests is that if a clinician suspects hormone excess, they must attempt to chemically suppress the axis. The high-dose dexamethasone test for Cushing's disease is a primary application of this logic. Benign endocrine tumors often show a subtle defect in their feedback set point. They ignore low-dose signals, but decrease hormone output when faced with a high-dose suppression attempt. Conversely, if a clinician suspects deficiency, they must attempt to aggressively stimulate the axis to evaluate its reserve capacity. Using ACTH to check adrenal junction or inducing hypoglycemia to trigger a growth hormone response forces the gland to demonstrate whether it can still meet physiological demand. These dynamic tests reveal the integrity of the endocrine loop, unmasking hidden autonomy or confirming a lack of reserve. Measuring a single hormone level in isolation is rarely diagnostic. To locate a defect, clinicians must analyze a hormone alongside its specific trophic partner. This matrix localizes defects by comparing command signals to target responses. In secondary failure, both trophic and peripheral signals are low. In primary failure, peripheral levels drop and the command signal spikes to compensate. In primary excess, autonomous target overproduction suppresses the trophic signal. If both levels are high, the feedback loop is effectively broken, suggesting either an autonomous trophic tumor or significant peripheral resistance. This logic provides a consistent framework for everything from gonadal failure to complex calcium disorders. Integrating molecular realities with paired axis testing provides a systematic way to evaluate endocrine disruption, clarifying the underlying regulatory feedback loops of the human body.